Good evening, doctors. So we will be starting today's class, and if I'm not wrong, we'll be discussing the ECG and arrhythmias. So before we start with the arrhythmias, let's just start with the basic ECG first. So there is important thing to understand that basically ECG has everything that you need to understand the physiology that is built up behind the arrhythmias. So to begin with, this is the heart, and this is the right atrium. This is the LA. This is LV, and this is RV. So here is the SA node. This is the SA node. This is the AV node, and this is the his bundle. So when the wave travels from SA node to AV node, we have a P wave. This is atrial depolarization, and then there is some delay here, and then it becomes QRS here. And then the repolarization is the T wave, as you can see in the ECG drawn here. So we understand that there is a P wave, then there is a PR interval, which is the time taken for the wave to travel from the atria to beginning of the ventricular depolarization. The QRS complex itself is the ventricular depolarization, followed by the relaxation phase, that is the ventricular repolarization, leading to a T wave, and any distance between them is the ST segment. So that is what defines the normal ECG. And then what we see here is that for us, the P wave is important. P wave has to be followed by a QRS with, of course, a PR interval. And then the QRS has to be followed by a T wave with a QT interval. So these are the major things that are required to understand the whole of the ECG and the arrhythmias. Now, if I have to define the arrhythmias, if the sequence goes like the PQRST, that is PQRST, if this is the sequence, then it is called a sinus arrhythmia. So I always try to tell my students that when you are looking at an ECG, you should follow it just like the algebra model of mathematics. Instead of looking at the ECG like this, you should look at it like this. So once you are doing this, for example, let us say what you have, that you don't see a P. Then you can, by looking at the ECG, you can just write that there is a QRST, QRST. So that means now you understand that there was no P wave. So whatever is happening at the level of just before the QRS. That means the ECG is beginning at AV node and then it is following. Hence the QRS, because it is generating its own wavelength, hence it is a broad QRS at that point of time. So if there is a PQRST, then it is called a sinus arrhythmia. And sinus arrhythmia means there will be P, there will be QRS, and there will be T, but it will be the rhythm will be different. That means it can be fast, it can be slow. So sinus bradycardia, sinus tachycardia, these are the sinus arrhythmias. They can happen with normal respiration also. So for true and false question, you can get. So normal variation is there. And in fact, with, let us say, with beta blockers, with calcium channel blockers, with ivabradine, with digoxin, with all of these drugs, you can actually bring down the heart rate by inducing a sinus arrhythmia. Now, sinus bradycardia is basically, bradycardia is whenever the heart rate is less than 60 beats per minute. And you have to define that there is a P wave before every QRS. That means there is a relation between PQRS. The causes of sinus bradycardia are physiological, are increased vagal tone, pathological are thyroid disorders, and then iatrogenic causes are drugs like beta blocker, digoxin. Environmental causes are hypoxia, and then another disease condition is myocardial infarction with right coronary artery or maybe inferior valve. If you want to treat, when do you treat? When the bradycardia is associated with either syncope or pre-syncope or with hypotension. Otherwise, you do not treat sinus bradycardia. So all you need is, maybe you can just make the patient to run, give them a sympathetic stimulus, and this is all you can do. And if the patient is symptomatic, you can try atropine or even temporary pacing. Now coming to sinus tachycardia. So sinus tachycardia is a regular rhythm with rate more than 100 beats per minute. There has to be a P wave before every QRS, which is a defining criteria for sinus rhythm. Physiological causes would be exercise, stress, fever. Pathological causes would be anemia, hypothyroidism, cardiac failure, certain drugs like LSD, amphetamines, deriphyllin, theophylline, thioxanthines, all caffeine, all of them can cause tachycardia. The treatment is to treat the underlying cause. Okay, so this was the sinus tachycardia. Now, when we talk of arrhythmias which are not in the sinus rhythm, that means they are different from the sinus rhythm. The top of the chart comes supraventricular arrhythmias. That means they begin in the supraventricular portion. Then there will be ventricular arrhythmias which begin in the ventricular portion. So right now, let's focus on the supraventricular arrhythmias. In the supraventricular arrhythmias, there will be atrial fibrillation as the king of supraventricular arrhythmias. So the ECG finding will be number one, no P waves. No P waves. Number two, QRS is irregular. RR intervals. So second is RR interval is irregular. So irregular rhythm, no P waves, fibrillatory baseline, variable PR interval. Causes are hypertension. The biggest cause is age more than 65. So more than 65 years of age, around 30% of the normal population will have atrial fibrillation. Hypertension, coronary artery disease, heart failure, very important. Valvular heart disease. Which valvular heart disease? Rheumatic heart disease with mitral valve involvement, because this will lead to enlargement of the LA. Hyperthyroidism because of hypermetabolic state. How it can complicate? It can complicate by thromboembolic events. So these patients can have stroke, heart failure, digital gangrenes, renal failure, infarctions. So all of them can happen. Mesenteric ischemia, all of them. Why? Because if the heart is not pumping, fibrillation is atrial fibrillation, means atria is not contracting. So atria is not contracting, so it is not pushing the blood into LV because during aortic atrial systole, basically there is no atrial systole happening. You have to understand that there is no atrial systole because there is no P wave. So what's happening is that the atria is just fibrillating. Now a fibrillating atria is like a washing machine. So in the washing machine, it is a circulatory motion. So that circulatory motion will only make clots in the blood. Those clots will be kept here in the left auricle. So at the time of embolism, these thrombi, they move from LA to LV, and from LV they are pushed into aorta to reach either the brain or any other organ, leading to thromboembolic events. So these patients have to be calculated on Chadwick score and anticoagulation be started. What is the management? Management, see, there is no much difference as the data goes between rate control and rhythm control. However, if it is an acute atrial fibrillation, young patient, you should always aim at bringing the patient's heart rate back to normal sinus rhythm. Why? This is my question to everyone. Why should we try to aim to bring a patient of atrial fibrillation back into normal sinus rhythm? Give me 1, 2, 3 reasons. Anyone? Anyone?
So that heart can pump normally.
So number one is atria can pump normally. Heart is pumping. Ventricular pumping is basically heart pumping. So that, and what will help? How the atria pumping will help?
because there will be no collection or that emboli in the atrium. That is less chance of forming emboli in the atrium.
Okay. So there is something known as atrial output. When we are discussing the cardiac output and cardiac cycle, so 20% of the cardiac output is given by
Yes,
the atrial
given by
kick.
the atrial peak. Yes,
Yeah. So that atrial kick will be absent in patients of
atrial
atrial
fibrillation.
fibrillation. So if you can get them back into normal sinus rhythm, this patient can go into a good atrial contribution of 20%. So that means one, cardiac output will be stabilized. Number two, as you said, there will be lesser chances of clot formation. Number three, there is something known as tachyarrhythmia associated cardiomyopathy. So people who are continuously in increased heart rate, no, even if they have a thyroid disorder, it is not thyrocardiac disease, it is known as. But in general, anything that leads to a persistent tachycardia can lead to heart failure by causing tachyarrhythmia or tachycardia associated cardiomyopathy. So when we are controlling the heart rate or even the rhythm of a patient who has atrial fibrillation, we are trying to prevent them from going into tachycardia induced cardiomyopathy. Is that okay? So these are the major three reasons why we want to bring them back to cardiac rhythm. Number one, it is a physiological rhythm. It contributes 20%. And that is why a patient who has a normal ejection fraction will not land up into heart failure because of atrial fibrillation. Imagine somebody whose EF is 30 to 35%. Out of that EF, the stroke volume, 20% is being contributed by the atrial contraction. Imagine if that also doesn't happen, these patients will go very rapidly into heart failure, pulmonary edema, because they cannot sustain a loss of cardiac output due to lack of atrial contribution. Is that okay? Then comes the strangest murmur. Oh, strangest arrhythmia. Oh, what is wrong with my pencil? So that is known as atrial flutter. Again, a supraventricular arrhythmia. What distinguishes it from atrial fibrillation is a regular QR, a regular RR interval. And instead of a fibrillatory baseline, it has a proper baseline known as sawtooth appearance, basically formed by lot of P waves clustered together, out of which only few can go. So this is atrial flutter. So this is SA node, or this is some abnormal aberrant atrial ectopic points. So they are all firing at AV node. Obviously, AV node cannot conduct all of them. So AV node will conduct one or few of them. So it is defined as this is one P wave which is traveled. Then there is one, one, two, one, two, three. So this is a atrial flutter with variable AV block. So this is a physiological phenomena of AV block. Why? Because if a P wave falls on the AV node during the refractory period, the absolute refractory period, it will not conduct. So all the atrial flutters, they have an inherent block in them that controls the heart rate, because flutter is very fast otherwise. So you will see a sort of pattern in flutter. The heart rate should be around 300 and above, and regular and rarely variable ventricular response. Cause is some re-entry circuit. Somebody who's sitting closer than the SA node and is firing repetitively on the AV node. Management is similar. So which are the drugs that are indicated in atrial fibrillation and flutter are A, B, C, D, E. So A is amiodarone, B is beta blockers, C is calcium channel blockers, D is digoxin, and E is electric shock. Okay. So when is electric shock given? It is the rule of thumb in any arrhythmia.
Hemodynamic instability.
With hemodynamic, very good, instability. So this is atrial flutter. Now coming to another important supraventricular arrhythmia is supraventricular tachycardia. It is a very common arrhythmia. We have a narrow QRS complex. P waves may be buried inside or they may be falling. I mean, P wave can come before, P wave can come after, P wave can be buried in the QRS complex. So all three are possible. Usually due to AVNRT, that is AV nodal reentrant tachycardia. So basically, AF was when atria is not contracting, it is fibrillating. Flutter is when somebody closer to the AV node is causing a re-entry circuit. SVT is when the re-entry circuit is either extremely close to AV node or it is in the AV node itself. So it is like running here only. And it can throw P wave backwards, known as retrograde P wave. That can also be there. Or antigrade P wave, or a P wave which is embedded inside the QRS. They are all supraventricular arrhythmias. Point to be noted is that there will be regular QRS, regular RR interval and a narrow QRS. Why narrow QRS? Because it is happening in the AV node or just proximal to AV node only. Now, rarely you can have an SVT with aberrancy. What is aberrancy word? Aberrancy means that it is not a normal pathway through which the things are being conducted. And the disease is known as WPW syndrome. So what happens is, here is the AV node, here is the SA node, and this is the his bundle. Imagine there is this point here, and it is conducting from this pathway directly to his bundle via bundle of Kent. So what is happening is it is actually bypassing the AV node, and this is the re-entry circuit that is established from that ectopic. But the problem is that it is delivering its current directly to his bundle, hence the QRS will be broad. So you will have a broad QRS tachycardia with a regular RR interval. And usually these patients are not in shock, they are not hemodynamically unstable, but you will have to define those patients as not having a ventricular tachycardia because they look just like ventricular tachycardia. So they are basically AVRT, where it is due to Wolff-Parkinson White syndrome, WPW, where there is an aberrant pathway leading to a broad QRS complex. So that is known as SVT with aberrancy. That can happen with atrial fibrillation also. So normally supraventricular arrhythmias are defined by a narrow QRS complex. That doesn't mean that they cannot be present with a broad QRS complex. It is only that it becomes a little complicated. So it is aberrant from the normal. That is why it's known as SVT or atrial fibrillation with aberrancy. Then you will need to define it, that because the drug will change. In ventricular tachycardia, you will prefer giving xylocaine IV, but in case of SVT or atrial fibrillation with aberrancy, although it will have broad QRS complex, you will prefer myodrone, digoxin, beta blocker, calcium channel blocker, and all these. Now the treatment for SVT, because I told you these patients usually are hemodynamically stable. It is one of the most benign arrhythmias. Everybody comes to the hospital. Nobody crashes and comes to the hospital, unlike other arrhythmias. So SVT can walk into your hospital. So vagal maneuvers, adenosine, beta blockers, calcium channel blockers, long-term prevention can help with catheter ablation. So you can actually burn that area which is throwing SVT. Now that we have done with the supraventricular major arrhythmias, let's discuss ventricular tachycardia. Now, ventricular tachycardia is defined by ventricular origin of the arrhythmia, number one. Number two, the QRS will be broad because now these are out of the picture. It is this only. Either this is the focus or this is the focus. Somewhere here, the focus is there and they are throwing back the arrhythmia. Hence, these patients have a monomorphic, one-dimensional running rhythm. QRS is broad, more than 120. Regular rhythm is there and no P waves because it suppresses the AV and the SA node. Most common reason is coronary artery disease. Second is cardiomyopathy. Third is electrolyte imbalance, for example, potassium issues and magnesium issues. What is stable VT? Stable VT is when the patient comes to you with QRS widening and they have a good pulse, BP of around 110. So they are very good patients to be treated. So stable VT, you give a myodrome, they revert back. You give beta blockers long, they are perfectly fine. You open up the blood vessel, coronary artery disease, absolutely fine. Unstable VT, you need to do immediate cardioversion. And pulseless VT, because there is no pulse, there is no QRS. So cardioversion is not the term used, although method is same, it is defibrillation. So immediate defib, pulseless VT, unstable VT, stable VT. And then there is big brother of ventricular arrhythmias. Major cause of sudden cardiac death worldwide is ventricular fibrillation. ECG shows irregular chaotic baseline. You cannot define anything. You cannot say this is P wave, this is QRS. This is just jig, 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 jig. And the patient is gasping, patient is cyanosed, patient does not respond, patient is literally dead, only the heart is fibrillating. So immediate shock, DC defibrillation, immediate defibrillation, because you cannot have a ventricular fibrillation with stable hemodynamics. सवाल ही पैदा नहीं होता. These patients, the ventricle is responsible for pulse generation, and here the ventricle is fibrillating like a washing machine. So there is no pulse. So immediate CPR plus defibrillation, immediate defibrillation. And if the patient is not responding and you have ECMO support, put the patient on ECMO and try to salvage the patient if they are neurologically intact.